I think I'm going to talk about, unless somebody else wants to, the comorbid conditions that are common with migraine. And I think one of the most important ones to look about is depression. Because a patient will walk into the office with depression and have migraine headaches, and they'll blame the migraine on the depression. And they'll say, well, you have headaches because you're depressed. And I tell my patients who've heard that all the time, I said, you tell me the following. If you have headaches all the time and you're not depressed, you must be schizophrenic. So tell me, you're down the dumps, you're schizophrenic. And I say, if you had cancer, it's eating through your bones, you weren't depressed, there's something wrong with you. But so we know that if you have depression, it somehow or other increases the risk of migraine, lifetime, and vice versa. If you have migraine, it increases the risk. And as David showed from the genetic testing, it's quite clear that the only disorder that's associated with the psychiatric disorders is migraine. Why? We don't know. It's a common genetic thing that leads to both. So it's not that migraine produces depression, depression produces migraine, but a common biology can lead to both. Maybe it's hypersensitivity, maybe it's increased reactivity. I don't think we know. Perhaps migraine is a disorder of increased sensory information, and the bipolar or depression could be increased emotional reactivity. I'm not sure, but I think you need to think about anxiety, depression, and bipolar disease, because if you don't treat it, your patients are really not going to get better. Stu, what factors can worsen or transform migraine from episodic to chronic?
Well, for the neurologist, it's worth remembering the history of this, that we had long defined episodic migraine as being headaches occurring less than 15 headache days per month, generally in discrete episodes of 4 to 72 hours, and chronic migraine, headaches 15 or more days per month with at least 8 days per month having migrainous features, and the duration of the attacks at least 4 hours per day, and generally for longer than 3 months. And in general, we conceive of chronic migraine as having evolved out of episodic migraine in most patients. The advent of the data on the monoclonal antibodies showing a magnitude of effect that is comparable between chronic and episodic migraine suggests that perhaps this division is not as clear as we thought. And a prospective population-based study called the CAMEO study by Richard Lipton and colleagues, in which headache diaries were obtained every 3 months on patients with high-frequency migraine, showed that the patients went from episodic in 1 month to chronic 3 months later, and back again in what Richard Lipton called a roller coaster of migraine. So before we actually talk about a directionality of going from episodic to chronic, it's worth considering the possibility that that border is not as hard as we previously thought. Now, David's colleague Todd Schwett has done functional imaging that suggests that at 15 or more days per month, one can fairly reliably say that the functional imaging in a blinded manner will look different than patients who have less than episodic, have less than 15 headache days per month. So there is some fluidity in the way that we're thinking about this, and it's clearly not a one-way street. But we do know, thanks to Lipton's work, a number of clinical features of episodic migraine that appear correlated with moving into chronic migraine. One of them is actually the number of headache days per month that a person has at the beginning of a year, and the more headache days that a person has, the more likely there is a transformation. Another is the use of acute medications. And as acute medication intake goes up, that appears to be correlated with a transformation from episodic to chronic. Other pain conditions, obesity, snoring, being in the top quartile of caffeine use. All of these are features that are associated with transformation from episodic into chronic, many of which actually are, if not remediable, at least modifiable. And then we have an opportunity, and we'll be talking about it later, of moving people from chronic back to episodic with the newer medications. And it's been extremely exciting and just almost exhilarating watching patients move from chronic back to episodic when we intervene. And so that's kind of a long answer to a short question, Steve.
Well, I think what you've really stated is the fact that the arbitrary dividing line between 15 or more and 15 or less is an artifact induced by Richard Nye a long time ago. And you're right. And I think the other problem is that chronic has so many meanings. In other disorders, it means it's been present for more than 3 months. In cluster, it means it's been present for more than 11 months. In migraine, it's whether how many per month. So I think it's semantic in part, but you're right. And I think that the fluctuation is normal. We see that in clinical trials. In clinical trials, you bring somebody in at the peak of their thing, and then you do something and they get better. Whether that's the placebo effect or resolution to the mean, we don't know, but you're right. But I think the crucial issue is what you said. There are risk factors that can help people regress and go back to baseline.